Hello, everyone, and welcome to the Arthritis Action Podcast. My name's Marc, as always, your host, and today I'm joined by Dr. Giles Hazan. Giles is a GP working in an extended role with NHS spine and chronic pain clinics on the south coast of England. And is here to talk to us not just about arthritis today, but about other conditions that can have an effect on your arthritis. So, Giles, welcome to the podcast.
Thank you very much for having me. It's a pleasure to be here, Marc.
Thank you. So, I've given a brief rundown already, but would you like to elaborate a little bit more about yourself and the work you do?
Yeah, thank you. So as you said, I come from a background of working as a GP, but like many of my colleagues, I've had one of these weird careers that tends to wind its way through a whole range of different things. So I started off wanting to be an orthopedic surgeon, and then moved to GP training, but I've always had an interest in psychology. I did a BSc in psychology when I was training at med school, and then ended up working as a GP partner for several years, and then moving into working as a GP, what we called then as a GP with a specialist interest, and then essentially the terminology has evolved a bit. So I now work as a GP in an extended role, which really means that I work in a role now predominantly with patients with chronic pain, in a community pain clinic. So this is a role which uses a lot of the GP skills, but in a more specialist area, which is currently chronic pain. And of course, within chronic pain, I'm dealing with lots and lots of people with a range of different types of arthritis, so, inflammatory arthritis, as well as osteoarthritis and a range of other chronic pain conditions as well.
Excellent. So it sounds like you're the man for this job then today.
Well, yeah, it's definitely, it's a really interesting area for me. And I think in some way, my slightly weird multi-route background has prepared me very well for it, because rather than just working in a silo in one speciality, I've had this sort of range of experience, which allows me to bring my GP generalist skills into the specialist arena of musculoskeletal and chronic pain. And I think that benefits everybody. And it's certainly a really interesting area for me to work in.
Absolutely. So let's put some of this knowledge to the test then. So as we're talking about other conditions that can affect arthritis, what are some of the most common types of these conditions then?
Well, there's all sorts. And I think it's a growing area in that there's well-established conditions which we know will influence osteoarthritis and other types of arthritis. And then there's a more sort of developing evidence base around some of the conditions that are more related to your metabolic health, so linked with things like obesity, diabetes, cardiovascular disease, hypertension, and so on. So we could start with the stuff that we know is strongly linked. There's a strong evidence base for the conditions that are associated with. So the most common thing, 10 million people in the UK with osteoarthritis. So let's start there. That's the big one, I guess. Mm-hmm. So the stuff that we know is associated with that will be obesity. It will be things like physical activity, previous injuries that can damage a joint or change the biomechanics, the way a joint moves and relates to other parts of the body. And also, interestingly, there's this relationship with inflammatory arthritis. So where you've got high-grade inflammation in joint, it can damage the joint surface and then lead to a secondary osteoarthritis, which normally isn't a high-grade inflammatory disease. So lots and lots of kind of conditions relate to osteoarthritis. But perhaps the bit that's interesting and developing is this relationship with obesity, which is more than just the relationship with putting load through a joint, that dreadful phrase that we used to use a lot of wear and tear, which we now identify there's a little bit more to it than that.
Yeah, definitely. So how does things like sort of obesity or carrying around too much sort of load on a joint cause a problem outside of the obvious one with arthritis?
Yeah. Well, it's still, that's still, of course, relevant, isn't it? So we know for every kilo we're carrying around our waist, when we're walking in things like running, well, that equates to sort of 5 times the amount or more of load through a weight-bearing joint like the knee. So the weight-bearing element of it is still really important, but the evidence now is showing that the obesity and that the lumpy fat that we gather around our middles isn't just this inactive padding. It's actually almost like an endocrine organ in itself. So the fatty cells that gather around our middles and elsewhere tend to act as generators of inflammatory chemicals in our body. So it's this inflammatory organ that will then increase a lower grade inflammation in joints. It's also associated with inflammation related to cardiovascular disease. There's even a suggestion this might link to things like depression and Parkinson's disease, so neurodegenerative conditions. So when you look at this relationship, you start to see these different patterns of symptoms that emerge with osteoarthritis. And I did a study when I was working in Brighton, looking at patterns in our patients with hip and knee arthritis that showed these trends emerging.
So as you sort of like mentioned things like sort of cardiovascular issues as well, what knock-on effect can that have to your arthritis?
Yeah, so it's a really interesting relationship, that, because I guess there is a relationship with people with osteoarthritis. You're more likely to have other long-term chronic conditions like cardiovascular disease. But I guess traditionally we always thought, well, if you've got a really painful knee or hip, and that's going to stop you moving, you'll be less active, and that might be why you then develop cardiovascular disease. But because of the mechanisms I've said already, it sort of suggests that actually having that sort of low-grade inflammation puts you more at risk of cardiovascular disease and osteoarthritis as a combined mechanism. So for me, it's a real win-win, because those conversations that I would have as a GP with patients around, let's look at the kind of modifiable factors, things you can change that might reduce your risk of heart disease, of strokes. So the example would be a patient that comes in with a high blood pressure. They're in their 40s or 50s, and we're just starting this conversation. I now can have that conversation about longer term improvements, but I might be having the same conversation with somebody who's presented with the first signs of mild to moderate knee arthritis. And when you look at their records, there's a good chance that many of them will have things like raised lipids or high blood pressure or borderline diabetes. And I'm a big fan of the path of least resistance. Okay, so if we can have an intervention or an approach that can benefit multiple different conditions, then that's a huge win.
You've touched on something I was going to ask as well about diabetes. So having previously sort of run a diabetes prevention program back in the day, I was wondering about the effects on that with people with arthritis.
Yeah, so we see a relationship. There's all sorts of interesting relationships with diabetes. So you look at the links with things like tendinopathy. There's a really good well-established evidence base for people with diabetes, not just having higher rates of osteoarthritis, but conditions like frozen shoulder, where you get a very stiff, painful shoulder, which can often last for several months. Other tendinopathies, so things like tennis elbow, Achilles tendonitis. There are all these different, the tendons, which are the bits that join our muscles to bone, can become irritable and painful, and there's a strong association with diabetes. So yeah, that link's pretty well established.
Do different conditions have different effects on different types of arthritis? Like, is there one that's going to be like really bad for a particular type of arthritis, and vice versa? Yeah,
so there's different, like you say, different relationship with different conditions. So if you take things like rheumatoid arthritis, again, the evidence would suggest that there is a link with obesity. There's a link with smoking increases the risk of rheumatoid arthritis. And of course, there's genetic links as well. We see links otherwise with things like obesity. It's not just arthritis. There's a strong relationship with obesity and back pain, for example. With gout, so gout is now the most common form of inflammatory arthritis in the UK, and that there are strong links to things like kidney disease. So gout's a condition, as you know, with a buildup of uric acid in our blood, and that can come from the food and drink we have. So there's a relationship with things like shellfish and red meats and beer and fortified wines and things like that. But anything that also affects our kidneys' ability to filter out urate from our bloodstream will impact on the likelihood of gout. So people with chronic kidney disease are more likely to get gout. Equally, medications for other conditions. So it's not just necessarily the conditions themselves, but if you look at things like diuretics that we use in high blood pressure, there's a relationship between them increasing the likelihood of gout. So there's links there. There's links with things like obesity and chronic pain. There's an increased likelihood of people experiencing chronic pain. And then when you move into the inflammatory arthritis and spondyloarthritis conditions, so things like central and peripheral spondyloarthritis with other types in that family, like psoriatic arthritis, as the name would suggest, there's a strong relationship between psoriasis and a type of autoimmune arthritis. Similarly, there's a relationship with inflammatory bowel diseases like Crohn's and ulcerative colitis, and even people who experience inflammatory eye conditions like uveitis and iritis that have an increased likelihood of suffering with inflammatory joint disorders. So just picking one of those with psoriasis, there are tools that are designed to help. Essentially, when we see patients in primary care or in dermatology clinics, clinicians and individuals dealing with those clients, those patients with psoriasis, are advised to be on the lookout for people then developing evidence of arthritis, because we want to jump on those quickly and get them to the right treatments as quickly as possible.
Are there any specific symptoms then that people should look out for? Again, it's another two-pronged question. Either if you have a condition, something like diabetes or, a heart condition, is there a symptom you should be looking for arthritis, and vice versa? If you have arthritis, is there a symptom you should be looking for that you might have one of these other conditions?
Yeah, you know what? It's interesting. I've been chatting with a patient who's a newly diagnosed psoriatic arthritis, which, of course, inevitably, as with all of us, as I'm sure you're the same, you encounter something and it always sends you back to the books to reread, what's going on, the latest research about it. And one of the things that came up, which I wasn't aware of or I hadn't remembered, was that people with psoriatic arthritis, you can develop psoriatic arthritis before developing psoriasis. So I've always had in my head that, well, if you've got psoriasis, we look out for you developing joint pains, swelling, stiffness, all of those sorts of things. But it can work the other way around too. So like you say, it is a bi-direction thing. I think there's lots of things. And in the pain clinic, that's part of my job, is when I see somebody coming in with widespread pain, part of the job is to screen for those rarer types of arthritis. So if you've got lots of joint pains, that will often come hand in hand with things like fatigue and low mood. But the symptoms that might make us think of rarer autoimmune conditions like connective tissue diseases like lupus or Sjogren's disease, we might look for symptoms like getting very, very dry mouth or dry eyes, oral ulcers, a rash that is worse in sunlight, a photosensitive rash, Raynaud's phenomenon, where you get a white, painful finger or multiple digits that behave like that. These are all things which would make us think, well, that's interesting. Maybe this is more than a kind of a more commonly encountered arthritis or chronic pain condition like fibromyalgia. And equally, the flip side might be somebody with inflammatory bowel disease like Crohn's disease and colitis. And in fact, I had somebody in clinic the other day who had come in, and when we dug into their history more, they were getting treatment for quite an aggressive inflammatory bowel disease and had come to me with chronic pain but no other diagnosis, and increasingly it was clear that the pattern of pain suggested this was an inflammatory pattern of joint pain of what's called enteropathic arthritis, so an arthritis that's linked to inflammatory bowel disease. And there are certain features that make us suspect inflammatory or autoimmune arthritis, so things like stiffness in the morning that goes on for at least half an hour, but more than an hour, So stiffness where the joints really don't move properly. Things like waking up in the second part of the night. So that means sort of around 3, 4 in the morning, which is characteristic of people with inflamed joints, because that's when our body's natural steroid cortisol is at its lowest point. So our natural steroid levels, and of course steroids are anti-inflammatory, wax and wane through the day. So they hit their peak late morning and they reach their lowest point at about 1 in the morning. So anybody with inflammatory disorders tend to find their pain gets really bad at sort of 2, 3 in the morning.
That is something I've heard loads, so that's really interesting to be able to give so I can now give a good answer for people when they ask me about that in our groups.
Yeah. But isn't that cool? I mean,
yeah.
I love that kind of stuff where you find out, and that's the reason behind it, is this diurnal variation in cortisol, right? So, yeah, it's science is cool, kids. I love finding this sort of stuff out. So that sort of thing, and it's probably worth mentioning with waking up at night. Waking up at night with pain is really, really common for almost any musculoskeletal painful disorder. So there's a distinction between people that find they're in pain and it's hard to go to sleep, or they're waking up multiple times, every time they turn over it's painful. So that's commonly encountered. That doesn't necessarily mean it's inflammatory. The distinction is somebody who'll go to bed quite happily, not in pain, and then wake up at 3 in the morning with raging pain and stiffness. And they have to get up an hour before everybody else because they've got to get their joints moving before they can do the school run and all that kind of thing. So yeah, it's all of these little giveaways and tells which would suggest in each direction what's going on.
So you can essentially get arthritis then from having another condition.
Yeah, absolutely. I suppose we would traditionally think of arthritis as just one condition. I mean, I think a lot of people out there might consider arthritis as just a single condition, but not that necessarily this is a great analogy, but cancer is not a single condition. There are lots and lots of different types. Arthritis, there are lots and lots of different types that present in different ways with varied treatments, and that the distinction between, so I've said this a few times now, sort of inflammatory arthritis versus non-inflammatory arthritis. So the inflammatory arthritis would be those conditions such as spondyloarthritis, rheumatoid, all of those sorts of things, versus our much more commonly encountered non-inflammatory arthritis. There's a bit of debate about that. There's maybe a little bit of inflammation in there, but not lots and lots of inflammation such as those other conditions. So the low or no inflammatory arthritis is the osteoarthritis, which is what most of us would encounter as an age-related phenomenon.
That's another thing I was going to ask, and you've touched again a little bit already, but is age a factor when it comes to other conditions, like the likelihood of getting them or the likelihood of the effect?
Yeah, but both. Yes, so definitely there's a relationship, with osteoarthritis, strong relationship that it increases with age, and that fits the model of the loading through joints. It fits the model of, for example, those people that might have blown out their knee with a football injury age 25, and then they get an earlier onset osteoarthritis, in their 50s because of the injury earlier on. So there's lots of age-related phenomena that comes with it. But yeah, equally, when we looked at it in the other way, that it's also because as we age, we tend to see increasing rates of obesity, of hyperlipidemia, which is a fancy word for raised cholesterol or abnormal cholesterol levels, high blood pressure, diabetes, cardiovascular disease, all of this stuff clusters together. So yes, multiple reasons there.
Does, as you said, age does have a factor. What about race or gender? Will that have any sort of bearing on any of this?
Yeah, so there are gender differences between different conditions, and women are probably, it's quoted as 2 to 3 times more likely to get rheumatoid arthritis. So autoimmune diseases are often seen as happening more commonly in women than men. Having said that, there's a little bit of, as the evidence base is gathered, there's unfortunately a little bit of gender bias in some of the studies that have happened over the years. So for example, spondyloarthritis, what we used to call axial spondyloarthritis, was always thought to be something that was much more common in men than women. And actually, as time has gone on, we've realised that those gender differences aren't quite as clear. I think possibly women are a lot more stoic than men. I don't know. maybe we're quicker to present when we're in pain. But yes, there's that's not quite as different as I think we considered it. So yes, definitely age plays a factor, and gender differences. So you'll see that with certain painful conditions which are multi-system conditions like lupus, systemic lupus erythematosus, SLE, will more commonly affect Afro-Caribbean populations. So there are some race and gender differences there. Yeah, sure.
Because I remember, again, back to diabetes again with that one, that there's certain sort of genealogies which tends to be higher in the population.
Yeah, it's really interesting, isn't it? I mean, yes, certainly with diabetes, that seems to be the case. Higher rates in Asian populations, Indian Asian populations. So yeah, there's variation out there globally. So it certainly does depend when you're working clinically, depending on what area of the country and of course what area of the world you're working in. And particularly with a very transient population, with people moving around a lot more, it certainly as clinicians we need to be aware of those differences for sure.
Right. So another one that we haven't talked about, well, we talked a little bit about it, but about medications, because obviously a lot of people with arthritis are going to be on medication. So what is that going to cause an impact in the sense that might lead to another condition that they're going to get?
Yeah, it's a bit of a minefield here. So one needs to tread carefully when discussing this, because it's important that we don't scare people away from using medication, nor do we want to drive people towards using it inappropriately. So as a GP, I always get a slight nervous twitch when you hear people say, always consult your doctor before starting medication, because you know that's just pushing a load of work into primary care where it's very difficult to get appointments and there's not enough GPs and all that kind of stuff. But of course, it's essentially true. We talking generically like this, there are so many individual variables, and that's one of the take homes, is that you've got to look at it on an individual basis, because yes, so common analgesics that we use for arthritis, in the NICE guidelines, so the National Institute of Clinical Excellence, that's what we use in the UK to guide our management of conditions like osteoarthritis. And what they tell us is that anti-inflammatories, which are what are known as the non-steroidal anti-inflammatories, so steroids have an anti-inflammatory action, but we also use other drugs that are not steroids that are anti-inflammatories as well. And that would be the commonplace stuff like ibuprofen is the one that we all recognise, and there's lots of others in that class, and they're generally pretty good for arthritic pain. So that might be one of the first drugs that we'd consider. Having said that family of drugs is also known to come with a fairly lengthy list of side effects, which all drugs do. If you read the leaflet in any packet of medication, there's a list as long as your arm. But the ones that are perhaps most relevant would be things like upsetting your stomach. So indigestion, heartburn would be the early warning signs, because anti-inflammatories, unfortunately, the stuff that we make in factories and they're made by pharmaceutical companies are very poor mimics of what our body naturally produces. So bog standard ibuprofen, yes, it works as an anti-inflammatory. It essentially turns down the action of an enzyme that creates inflammatory chemicals in our body, which is great. That's what we want. Unfortunately, it also tends to affect the production of stuff that protects our stomach. It also affects the way our kidneys work, and it's fairly indiscriminate in the way it does that. So all of that group of anti-inflammatories like ibuprofen, naproxen, diclofenac, these are all the ones that we might use, have got a risk of increasing the likelihood of stomach ulcers, of indigestion, of kidney dysfunction, and long-term cardiovascular problems as well. So as a general rule, we would avoid those if you've got a history of a hiatus hernia or a stomach ulcer. They are quite risky. You can end up getting bleeding from these ulcers, and that for example, if you're on blood thinners, would be catastrophic and even life-threatening at its very worst. So the rule of thumb is if you're using them, be aware to look for any signs of indigestion, and to avoid the longer term effects, you probably want to avoid using them for months and months and months, longer term. So it's a balance of risk and benefit. There are some that came out a little while ago called COX-2 inhibitors, these drugs like celecoxib, rofecoxib, that sometimes are used. And we thought they were going to be the solution for this problem. And then we found out that whilst they don't tend to upset the stomach so much, because they're, as the name suggests, they select out just the bit that we were talking about, or we thought they did, but we've now found that there's an increased risk of heart problems if they're taken long term. So it's challenging, and that's just the anti-inflammatories. When you look at, certainly once you're into the drugs that are used they're known as disease-modifying anti-rheumatic drugs, DMARDs, that are used for things like rheumatoid arthritis and psoriatic arthritis. There's, again, a long list of other side effects and problems, whether it's affecting the way your body produces blood cells or your liver function. But, having scared everybody to death with that list of things, it's important to say that we know this, so we screen very carefully to look for people if they're going on these sorts of drugs. They have regular testing. We look out for any complications and side effects, and we would adjust the doses accordingly. So this is a reason why it's important that you certainly have these discussions with the doctors prescribing the medication, that it's based on an individual. Everybody's different, so we need to know what an individual's health issues are outside treating the arthritis. And there's a constant monitoring process for some of those, certainly those more complex drugs. So it's not that you shouldn't take them, but we just need to make sure that they're adequately monitored. The vast majority of people on these medications do really well and don't have these problems. But we want to go into it with our eyes wide open and make sure people don't develop those complications.
I think it's something we've harked on a lot about, is it just how important like having communication with your doctor or whoever's prescribing to you, just making sure you're telling them about if you have any side effects, if anything's happening, any worries you have, because then without that information there's nothing you guys can do about it, really, is there?
No, and I think, this is why the sort of work that you're doing with this podcast and Arthritis Action do in general is so important, because I guess I grew up, and many people did, with this sort of separation from medicine and doctors as being this sort of almost otherworldly profession and a knowledge which is just not accessible to us mere mortals. And actually, certainly the approach as once I qualified as a doctor and as we go on is that it's really important that patients, individuals, clients, whatever term you want to use, take ownership over their health. Now that can be in identifying, what things you can do as an individual to help your own health, but also really importantly, it's you have a right to know what's going on, what drugs are being put in your body, why you're taking them, what are the effects. Inform yourself. Knowledge is power. So if you're in a situation where you've been newly diagnosed with osteoarthritis or rheumatoid or wherever it is, actually having a look at some of the resources that you guys have through your websites, and there are others out there, obviously, going along to find out more about it raises the awareness. So when it comes to things like medication and knowing what the side effects are, what's significant and what's not significant. So I did some teaching around managing uncertainty, and one of the causes of uncertainty in the patient population is people just don't know what to look for. Of course you'd report it if you knew it was important, but if you're not told or advised, or you've not given information about what symptoms to look for and what to do with that information, then how on earth would you know what to do?
Absolutely. So I guess that's important then if you also are talking to a doctor about another condition, like if you're going there like with suspected like heart issues, kidney issues, or anything like that, is it important to then tell them that you have arthritis when sort of discussing them with that? Will that make a difference to their treatment?
It's and again, this is what we hope we achieve as GPs, and in for all clinicians. Actually, I think we're getting better at a more, what we describe as a more holistic view, is rather than just treating the hip arthritis. We're treating the whole person. So yes, absolutely. I think again, having an understanding. Okay, I know I've got these various different conditions, and perhaps even asking, if I'm using this medication for my arthritis, is that going to cause any problems for my kidneys? Because I know I've got high blood pressure, and I get a regular check on my kidney function, for example. So yes, I mean, a gentle curiosity, I think, would be what I would encourage.
Right. Yeah, I think again, it's another thing just to mention. I liked that term, like, your body as a whole, because it's very easy everyone to like compartmentalize, like you have this condition and this condition and this condition, as if they're completely separate and have nothing to do with each other, but they're all in the same body, so they're naturally going to affect what
Yeah,
happens inside that body.
yeah. We you can get into rather a philosophical discussion on this, and this might not be the right moment to have it, but we as clinicians, and really as human beings, we try to categorize and put things in nice, neat little boxes. It's a great way to learn about the way the body works. It's great for us to make sense of the world around us. But of course, that's not really the way the world works or our body works. Everything is interconnected, and there are lots of interesting, complex interactions between these different systems. So yeah, I think seeing the person as a whole and boiling it down to what's important to the individual, not just what's wrong with them, for example, is good. And I think there's also a strong positive message to take from this. Is this is about empowering the individual to make a difference themselves for their wholeness as well. So, as I said, going back to that principle of having a win-win, managing things like your diet, your weight, your exercise levels, really modest changes in those things can make a big difference. And a conversation point I have with a lot of my patients in the pain clinic is, having already established that most of the drugs that we use for pain are a bit rubbish for chronic pain, the good news is recognizing that they're designed to mimic what our body naturally produces. These drugs are designed to fit into receptors in our body. They're not very good at doing it, but those receptors are there in our body because we make our own opioids, we make our own anti-inflammatories, we make our own antidepressants. So the real trick is how to access what a psychologist colleague of mine describes as the internal pharmacy. And I love that as an expression, because we can unlock all of those benefits that come from movement, activity, mindfulness, meditation, being with people, communicating, that sense of joy and pleasure. All of these things actually create those chemicals in our body, which are the natural analgesics and bits and pieces. So yeah, it's great stuff.
Excellent. So, I mean, my next question was going to be about, like, what can we do to reduce the risk of these conditions?
Yeah.
But I mean, I guess you kind of already touched on it already, I suppose, with diet.
Well, you know
exercise.
what? I would add something to that, Mark, which is, I think that it's much more complicated. And I think one of the messages, any of your listeners who are overweight with arthritis will probably be rolling their eyes at this point, saying, "Oh, all I ever hear is I need to lose weight." Managing obesity and weight is much more complicated than simply, well, you need to eat less. It's tied in with so much more about our relationship with food, our relationship with our bodies. So I don't want to be reductive about this. And we can list these things like it's a real simple menu, and it's really not. It's much more complex.
Mm-hmm.
Having said that, one of the things that I saw in the evidence base from some public health colleagues of mine that really helped me get my head around it a little bit was just how much of a difference doing a little bit makes. So a lot of us will get put off by the fact that, oh gosh, well, I'm never going to be a size 8 or a 10 or whatever, therefore what's the point? What's the point in doing 10 minutes walking a day or whatever it might be? And when you look at the evidence, it's really clear that the biggest improvement in mortality and morbidity, so increase in lifespan, reduction in health problems, is in those people that go from doing nothing to something, rather than those people that go from doing something to a lot. So that's a very my kind of ABC spot the dog description of that graph. But you can break it down into these. They quantify the amount of exercise as METs, as the amount of activity you do. So the chief medical officer says we should all be, as adults, we should be doing 150 minutes of exercise a week. And if you can that's the point, when you get up to that level of activity in a week, that's where you see this really steep drop off in mortality. So it's really big difference. It might sound a lot to somebody who doesn't do very much, but that moderate exercise includes going for a brisk walk or mowing the lawn. We're not talking hitting the gym and doing high intensity stuff. This is the kind of stuff which often goes under the radar. So there was a really interesting study in the British Journal of Sport and Exercise Medicine recently that looked at the wearables where you can wear a watch or a monitor on your body that will tell how much activity you're doing, and people going to the gym consistently over-report or overestimate how much exercise they're doing because they're standing next to the weight machine having a natter and ogling the person on the bike or whatever it is, versus the people that don't do, the people that under-report their activity will not be the gym goers. They're people that don't recognise that walking kids to school counts as that moderate exercise, that, going to the shopping, mowing the lawn, all of that counts. So, this is essentially, I'm trying to make a bid for the fact that modest level of activity is worth it. It does make a difference. If you lose a little bit of weight, if you start doing a little bit of activity, it really can make a big difference. So it's worth doing.
Definitely. I'm a big fan of the word activity. It's like exercise has almost become a bit of a dirty word. There's too many negative connotations with it now where, people think of going to the gym or dressed in lycra and CrossFit and all that type of stuff, where it's literally just doing things. Activity is sort of the term I prefer these days because it's not scary, and it makes, as you say, makes people realize that that's just what you need to do just to remain kind of healthy, is just move, do things.
Yeah. Motion is lotion. The principle of movement is the other word that comes up a lot in the pain clinic. Obviously exactly as you should say, exercise is quite threatening because that evokes images of trudging around a sports pitch at school, or a lot of people's experience of sport and exercise is often quite negative.
Absolutely,
it doesn't necessarily bring back very happy memories. So meaningful movement. The big thing for me is sustainable change. So you can get really motivated and do really every day 30 45 minutes of brisk walking, whatever it is, but that's probably not sustainable for most people. So it's got to be something that you can keep going. And the boring bit is that change often takes quite a long time to be noticed, doesn't it? We live in a world of immediate rewards. We're not very good at delayed gratification now as a society. And what we're asking people is you've got to recognise those gains across months and years rather than days and weeks. So it's a different time scale.
Yeah, long-term and short-term goals are something we're always a big fan of. And I mean, have a listen, anyone listening, have a listen to our planning and pacing episode where we do talk a lot about that, just about how your ultimate goal, that might be fine, but don't expect it to show up within the next week. You might be there in a few years, but there's loads of steps along the way to make sure that you do get there.
Yeah, agreed.
Great stuff. So if you'd like to sort of follow up with, as we mentioned, there's loads of information available on the internet. Obviously, do be careful where you get all of that stuff from, somewhere like the NHS or from Arthritis Action. Ideal choices, if you ask me. But if you do want to look at our website, there's loads of great stuff on diet, exercise, pacing, planning, all of that type of stuff. We've got loads of fact sheets, webinars, resources, loads of different stuff for you to have a look at, whatever your particular interest may be. And that's it for today, really. So if you want to go to that website, it's www.arthritisaction.org.uk. Or if you have any questions, feel free to contact us at the email address podcast@arthritisaction.org.uk. And Giles, thank you very much. That's been really interesting.
Not at all. Thank you very much for having me. Great to chat about it.
Great. Thanks, everybody. Bye-bye.